Clinical evaluation of nerve injuries to the upper extremity. Nerves originate from the spine. It provides sensation to the skin and it allows motor power and function to the muscles. When nerves are injured, many structures are affected. So let's examine the cervical spine nerve roots. So if you have a herniated disc between C4 and C5, that will affect C5 nerve root. You will know if a nerve is injured or not by looking at three things: the motor function, the sensory function, and the reflex. So when we talk about C5 nerve root, let's talk about the motor function: shoulder abduction and elbow flexion. The deltoid is C5 nerve root. So we're talking about shoulder abduction. The deltoid is C5 nerve root. The biceps is C5 nerve root. How about the sensation? Sensation around the shoulder area. How about the reflexes? The biceps reflex is primarily C5. If we go to a herniated disc between C5 and C6, that will affect C6 nerve root. The motor function is elbow flexion and wrist extension. The extensor carpi radialis longus and brevis. You can see the sensation of C6 dermatome is at the thumb and index finger. Reflexes. Brachioradialis reflex is C6. So let's take a herniated disc between C6 and C7. It will affect C7 nerve root. C7 motor function will be an elbow extension, wrist flexion, and finger extension. The triceps is C7 for elbow extension. The wrist flexors is C7 and the finger extensors is C7. So give you like 7: wrist flexion and finger extension. And the sensory C7 is the middle finger. So if you see in the exam, sensation of the middle finger is affected, that is C7. So the disc is herniated between C6 and C7 level. The reflexes of C7 is the triceps reflex. Herniated disc between C7 and T1, that will affect C8 nerve root. Motor function C8 is finger flexion. C8 finger flexion from the flexor digitorum superficialis and profundus. The sensory C8 is for the little finger, the ring finger, and the ulnar part of the forearm, as you can see here. This is a safe way to remember the sensation of the cervical nerve roots. C5 sensation is around the shoulder area. C6 will be the thumb area. The middle finger will be C7. The little finger will be C8. And this is the area of T1. How about a disc herniation between T1 and T2? A disc herniation between T1 and T2 will affect T1 nerve root. The motor involved will be abduction and adduction of the fingers. And you can see the areas of sensation of T1 is around the medial aspect of the elbow. This is a chart summarizing the nerve root and the important nerve function of every nerve root. Let's now see the brachial plexus and discuss the injuries and the result of injuries to the structures of the brachial plexus. And we're going to start by the medial winging of the scapula. The medial winging of the scapula occurs due to injury of the long thoracic nerve. The long thoracic nerve comes from C5, C6, C7. It is a long nerve, and it supplies the serratus anterior muscle. The medial winging of the scapula is caused by paralysis of the serratus anterior muscle, which is supplied by the long thoracic nerve. In the medial winging of the scapula, the medial scapular border displaces itself from the thoracic cage, and it becomes more prominent during shoulder flexion. In the long thoracic nerve injury, the medial winging, the scapula elevates, and the direction of the winging is medial. In the accessory nerve injury, lateral winging, the scapula depresses, and the direction of the scapula is lateral. The medial winging is more common than the lateral winging. The medial winging of the scapula will be worsened by arm flexion. The lateral winging of the scapula will be worsened by arm abduction. In the lateral winging, there is usually a history of neck surgery, especially in the posterior triangle of the neck. Medial winging of the scapula can also be a part of the findings in a preganglionic or preclavicular brachial plexus injury. Medial winging of the scapula is checked by having the patient perform the wall push-up test for serratus anterior muscle weakness. Suprascapular nerve. It supplies the supraspinatus and infraspinatus muscles. The suprascapular nerve arises from the upper trunk of the brachial plexus. The suprascapular nerve passes under the transverse scapular ligament at the suprascapular notch. Here you can see the transverse scapular ligament, and you can see the artery runs above the ligament and the nerve runs below the ligament. The artery and the nerve join and then pass through the sphenoglenoid notch under the inferior scapular ligament, as you can see here. The suprascapular nerve gives branches to the supraspinatus muscle and branches to the infraspinatus muscle. Nerve compression at the suprascapular notch affects both muscles, causing decrease in abduction of the shoulder and loss of external rotation of the shoulder with the arm to the side. Nerve compression at the sphenoglenoid notch affects only the infraspinatus muscle, causing loss of external rotation of the shoulder. The sphenoglenoid notch compression can occur in volleyball players and is usually associated with ganglion cyst or slap tears. The infraspinatus muscle is the primary external rotator of the shoulder. The latissimus dorsi muscle is the broadest muscle of the back, which is partially covered by the trapezius muscle, as you can see here in this diagram. The latissimus dorsi is supplied by the cervical nerve roots of C6, C7, and C8 through the thoracodorsal nerve. The thoracodorsal nerve arises from the posterior cord of the brachial plexus between the upper and the lower subscapular nerves. The function of the latissimus dorsi muscle is tested by asking the patient to abduct the arm, then ask the patient to abduct the arm against resistance. The muscle belly of the latissimus dorsi muscle can be seen and felt. Now let's go to the subscapularis muscle. Subscapularis muscle is innervated by the upper and lower subscapular nerves, which arises from the posterior cord C5, C6, C7. The upper and lower subscapular nerves come from the posterior cord of the brachial plexus. How do you test for the subscapularis muscle? You can do the lift-off test. If the patient is unable to lift the hand of the lower back, then the muscle is weak and a tear of the subscapularis tendon is suspected. Lift-off leg test is another test. The examiner will hold the patient's hand away from the back of the lumbar region and let go. The patient will be unable to keep the hand away from the back if the tendon is torn. The belly press test. The patient presses the palm of the hand against the abdomen with the wrist in neutral position. This is an example of an intact subscapularis tendon. A positive sign for the belly press test occurs if the patient is unable to press his belly without wrist volar flexion or without the elbow falling posteriorly. The teres major is supplied by the lower subscapular nerve. The upper and lower subscapular nerves come from the posterior cord of the brachial plexus. How do you examine for the teres major muscle? The patient is abducting the elevated upper arm against resistance. You can see the muscle belly of the teres major and you can actually feel it. Above this muscle is the teres minor muscle, and in between the two muscles, the teres major and the teres minor, you will find the quadrangular space that contains the axillary nerve and the posterior humeral circumflex artery. A vague pain posteriorly in this location may indicate entrapment of the axillary nerve in the quadrangular space. The triangular space will be more medial, and the triangular interval is slightly distal, as indicated in this diagram. The teres minor is a narrow muscle which originates from the posterior lateral surface of the scapula, and it inserts into the greater tuberosity of the humerus. The teres minor is innervated by the posterior branch of the axillary nerve. Here you can see in this diagram the posterior branch of the axillary nerve supplying the teres minor. It is the same nerve that gives cutaneous innervation to the lateral part of the shoulder. The teres minor contributes to important anatomical spaces in the posterior part of the shoulder. The teres major contribute to three important anatomical spaces. The teres minor, the smaller muscle, contribute to only two important anatomical spaces. A good way to see the teres minor muscle is on the sagittal view of the MRI, as you can see here. The infraspinatus is the main external rotator of the shoulder with the arm to the side. The arm is abducted. The teres minor muscle is the main external rotator of the shoulder with the arm abducted. Clinical examination. The horn blowers test. The test is used to determine the strength of the teres minor muscle. The patient and the examiner are both standing and the patient's arm is elevated to 90 degrees. The patient's elbow is then flexed to 90 degrees, and the patient is asked to laterally rotate the shoulder. Weakness and or pain against resistance signals a positive test. The axillary nerve. The axillary nerve is the most commonly injured nerve due to shoulder dislocation. It occurs in about 5% of shoulder dislocations. After shoulder dislocation, the patient will be unable to abduct the shoulder and the deltoid will have no muscle tone. The supraspinatus muscle will be firing, and you will have decreased sensation or absence of sensation on the area of the lateral shoulder. After shoulder dislocation, if you can abduct the shoulder, rule out rotator cuff tear and examine the shoulder sensation. There's another scenario when the intact rotator cuff muscle may abduct the shoulder and confuse the examiner. It is important to check the sensation over the shoulder area. Regardless, if the rotator cuff is intact or torn, the sensation over the skin of the lateral shoulder will tell you if there is an axillary nerve palsy or not. Injury of the axillary nerve varies from neuropraxia to complete tear of the nerve. After passing through the quadrangular space, the axillary nerve divides into an anterior and a posterior division. The anterior division curves anteriorly under the deltoid muscle, and the anterior division supplies the anterior and the middle part of the deltoid, and the posterior division supplies the teres minor muscle and the remaining posterior part of the deltoid muscle, as well as the skin over the shoulder. The anterior branch of the axillary nerve is located 5 to 7 centimeters distal to the lateral edge of the acromion. Don't exceed deltoid splitting approach more than 5 centimeters below the acromion, or you may risk injury to the axillary nerve. How do you examine for the axillary nerve injury? Ask the patient to abduct the arm against resistance, which will examine the deltoid muscle strength. The anterior and middle fibers of the deltoid muscle can be seen and felt. So what do you do when the axillary nerve is injured? Give the patient a sling for comfort, physiotherapy, follow the patient progress clinically. Usually the nerve will recover. Get EMG and nerve studies. You will see biphasic waves at 3 to 4 weeks if the nerve recovers. However, if the nerve does not recover, you will see fibrillation potentials and P waves in the EMG. Failure to abduct the shoulder after 4 to 6 months despite physiotherapy, then the condition is permanent and the patient may not achieve abduction of the shoulder without recovery of the deltoid. Since the intact rotator cuff muscle failed to abduct the shoulder and to take over the job of the deltoid, then this condition is permanent. Then you got two options: exploration of the nerve for release, repair, or reconstruction of the nerve. You reconstruct it by a nerve graft. Or you do tendon transfer, the transfer of the trapezius to the proximal humerus, and the result of the transfer is usually poor. The posterior cord of the brachial plexus ends by giving the two terminal branches. the axillary nerve, and the radial nerve. Radial nerve compression or injury may occur at any point along the course of the nerve. You can have very high radial nerve palsy at the axilla. You can have a high radial nerve palsy in the upper arm to the elbow. And you can have a low radial nerve palsy below the elbow. You can also have Wartenberg syndrome near the wrist. So let's start with the very high radial nerve palsy at the axilla. Nerve compression at the axilla, all motor and sensory function below the axilla will be affected with injury at this level. With injury to the radial nerve at the axilla, there will be loss of function of the triceps with weak elbow extension. The patient will experience wrist drop due to loss of function of the extensor carpi radialis longus and the extensor carpi radialis brevis muscles. The radial nerve gives 3 branches. Just above the elbow, give the brachioradialis, the extensor carpi radialis longus, and the extensor carpi radialis brevis. The longus and the brevis are wrist extensors. Here is a case of wrist drop due to loss of function of the extensor carpi radialis longus and brevis. Patient is unable to extend the wrist. There will also be a loss of finger extension. Put the wrist in extension and ask the patient to extend the fingers. Sensory loss will also be seen in the distribution of the superficial branch of the radial nerve, as you can see here in this picture. Causes of compression or injury to the radial nerve at the axilla. Saturday night palsy. Alcohol could be a factor as the person falls asleep with the back of their arm compressed by a chair back or a bar edge, and the honeymoon palsy from another individual sleeping on one's arm overnight, compressing the nerve. Crutch palsy, compression on the nerve from walking with crutches. How about high radial nerve palsy at the upper arm and around the elbow? Radial nerve injury can occur from compression or a fracture that can cause injury to the nerve within the spiral groove. And here you can see the spiral groove in this diagram. You can also have radial nerve injury from fracture of the distal third of the humerus. All motor and sensory function will be affected below the level of this injury. The radial nerve is vulnerable, usually due to a fracture of the humerus at the spiral groove. Injury may also occur below the spiral groove when there is a fracture in the distal third of the humeral shaft. So what happens when there is an injury of the nerve at the spiral groove? You're going to lose innervation and sensation through these branches. The same pattern of injury also will occur if there is injury just above the elbow. So what is Holstein-Lewis fracture? It's an injury to the radial nerve at the distal third of the humerus, and it will cause wrist drop and weakness of finger extension. Sensory loss will also be seen in the distribution of the superficial branch of the radial nerve. How about low radial nerve palsy below the elbow? Causes entrapment of the posterior interosseous nerve at the arcade of Froch. This is one of the most important causes. The arcade of Froch is a site of radial nerve entrapment, which may cause injury of the posterior interosseous nerve. Here you can see the superficial branch of the radial nerve, and you can also see the posterior interosseous nerve, and how the entrapment is at the proximal edge of the supinator. With injury to the posterior interosseous nerve, the patient will experience difficulty with extension of the fingers only. The patient will be able to dorsiflex the wrist. There will be no wrist drop. There will be loss of finger extension. Make sure you ask the patient to extend the wrist first when examining finger extension. That will clearly show weakness of finger extension during the exam. Fracture dislocation around the elbow. Montagia fracture. It is a fracture of the proximal third of the ulna with dislocation of the radial head. Montagia fracture can cause compression to the posterior interosseous nerve, so the motor function below this area will be affected by the injury. The posterior interosseous nerve is purely motor and no sensory loss. Neurovascular examination is very important because nerve injury, especially injury to the posterior interosseous nerve, is not uncommon. And if it happens, the treatment is usually to observe the patient. Examine the patient on presentation by examining the patient for loss of finger extension. Wartenberg's syndrome, entrapment of the radial nerve around the wrist. Compression of the superficial branch of the radial nerve around the wrist area. The pain is located approximately 8 cm proximal to the radial styloid. Wearing a wrist watch may irritate the nerve. The nerve is located between the brachioradialis muscle, volale, and extensor carpi radialis longus on the lateral side and slightly dorsal. Here you can see the Wartenberg's point. Patient will complain of pain and paresthesia on the dorsum of the hand with positive Tinel's sign. How do you examine for the radial nerve function? You can examine the radial nerve by multiple tests. For example, testing the triceps. The patient is flexing the elbow and ask the patient to extend the elbow against resistance. You can feel and see the long and the lateral head of the triceps muscle. Also, for the radial nerve, we can examine the extensor carpi radialis longus. Ask the patient to extend and abduct the hand at the rest against resistance. The extensor carpi radialis longus muscle and tendon can be seen and felt. Also for the radial nerve, we can examine the brachioradialis. Flex the forearm against resistance with the forearm in neutral position between pronation and supination. The brachioradialis muscle can be seen and felt. The musculocutaneous nerve. The musculocutaneous means that it supplies muscle and has a cutaneous branch. When you say muscle, we're talking about the biceps. When we're talking about cutaneous, the musculocutaneous supplies sensation to the lateral part of the forearm. The musculocutaneous nerve arises from the lateral cord of the brachial plexus, so it supplies the lateral half of forearm sensation. Lateral cord, lateral forearm sensation. In fact, it is the primary nerve supply of the muscles of the anterior compartment of the upper arm, coracobrachialis, the brachialis, and the biceps. And it supplies sensation to the lateral half of the forearm. The musculocutaneous nerve is the distal contribution of the lateral cord of the brachial plexus. It predominantly arises from the C5, C6 level, with some contribution from C7. Function of the muscle, the biceps, is flexion of the elbow and supination of the forearm when the elbow is flexed. How about musculocutaneous nerve palsy? You'll find weakness of elbow flexion, weak forearm supination, and numbness in the anterolateral forearm that stops at the wrist. Median nerve injury. The median nerve can be compressed at many points along its course. About 1% of people have a supracondylar spare on the medial side of the humerus, about 5 centimeters from the epicondyle. The nerve runs deep to the supracondylar spare and Strather's ligament, which may cause entrapment of the nerve. What is Strather's ligament? It is a ligament that bridges the spare to the medial epicondyle. The median nerve usually passes under the ligament along with the brachial artery or its ulnar branch. Clinically, the patient will experience pain, gradual hand weakness, and sensory loss in the median nerve distribution. The patient may not be able to perform the OK sign. Tenel test may be positive. The test is considered positive if symptoms of tingling worsen while tapping on the spare. Occasionally, the spare can be felt. How about pronator teres syndrome? Pronator teres syndrome is a compression of the median nerve at the level of the elbow, which occurs more in females. In the forearm, the median nerve runs between the two heads of the pronator teres muscle, and then it lies between the flexor digitorum superficialis and the flexor digitorum profundus muscles. Pronator teres syndrome could be associated with medial epicondylitis. The principal symptoms of numbness in the radial 3.5 fingers, as well as thinner weakness, may be mistakenly attributed to carpal tunnel syndrome, but it is not a carpal tunnel syndrome. Potential sites for entrapment of the nerve include: the most common cause is due to compression of the median nerve between the two heads of the pronator teres muscle. It occurs in people who perform repetitive, forceful pronation of the forearm. Compression due to thickening of the bicipital aponeurosis. The aponeurosis crosses from lateral to medial over the antecubital fossa, and it may irritate the median nerve. Compression of the nerve from the fibrous arch of the origin of the flexor digitorum superficialis. Clinical presentation: paresthesia in the lateral 3.5 fingers may occur with compression of the median nerve at the elbow region. Symptoms are similar to carpal tunnel syndrome, but the symptoms are worse with rotation of the forearm. Patients will complain of dull aching pain over the proximal forearm with no night symptoms. Pain is usually worsened by repetitive or forceful pronation, and you can find tenderness on palpation of the pronator teres muscle. The median nerve gives off a palmar cutaneous branch before entering the carpal tunnel. So sensory disturbances over the palm of the hand occur due to involvement of the palmar cutaneous branch of the median nerve, and this occurs proximal to the carpal tunnel itself. Here you can see the palmar cutaneous nerve arises before the carpal tunnel. Sensory disturbance in this area indicates median nerve problems proximal to the carpal tunnel. This differentiates between carpal tunnel syndrome and pronator teres syndrome. This is an important point. There are no specific provocative tests used to localize the site of compression that produce the pain and distal paresthesia. In pronator syndrome, Tinel sign at the wrist will be negative. Phalen test will be negative. Median nerve compression tests are negative at the carpal tunnel. However, there will be a positive Tinel sign at the proximal forearm. Also, there will be an abnormal sensation in the palm of the hand. The pronator teres muscle can be assessed as the cause of the median nerve compression. Resisted forearm pronation with the elbow extension will test for compression at the two heads of the pronator teres muscle. The patient forearm is held in resisted pronation and flexion. While remaining in a pronated position, the forearm is gradually extended. Compression of the median nerve can also be tested by resisted elbow flexion with forearm supination. Indicates compression of the median nerve at the bicipital aponeurosis. The bicipital aponeurosis is a hot topic nowadays, where some doctors release that under local anesthesia. The resisted contraction of the flexor digitorum superficialis to the middle finger that will test compression at the flexor digitorum superficialis arch. How about carpal tunnel syndrome? The clinical picture of carpal tunnel syndrome, usually the patient will complain of pain, numbness, and paresthesia in the palmar aspect of the thumb, index, and long finger. It is at the median nerve distribution. Symptoms of carpal tunnel syndrome occur more at night. These symptoms wake the patient up from sleep, causing the patient to shake the hand in an attempt to resolve these symptoms. Positive Tinel sign. Percussion of the volar wrist crease produces electric sensation distally to the fingers. Phalen test is usually positive. How Phalen test is done? It is done by flexing the wrist for 60 seconds. This will increase the carpal tunnel pressure temporarily and produce the symptoms. If the test is positive, the patient will have numbness and tingling in the hand and wrist. Positive compression test, Darkins test. This is the most sensitive test. The examiner places even pressure with two thumbs directly over the patient's median nerve in the carpal tunnel for about 30 seconds. Reproduction of symptoms in the distribution of the median nerve means that the test is positive for carpal tunnel syndrome. A self-administered hand diagram is extremely helpful. It is the most specific test for carpal tunnel syndrome. The patient should highlight the areas where they are experiencing the symptoms. Patient may complain of thenar atrophy, weakness, or clumsiness of the hand. The patient history and examination is an indication for carpal tunnel syndrome. Carpal tunnel syndrome is a clinical diagnosis. The nerve is much like a truck passing through a tunnel. The nerve should be able to pass through the tunnel with ease and without friction. So if the tunnel is narrow, then the nerve cannot pass. And if you want the nerve to pass, then widen the tunnel. And we widen the tunnel by cutting the transverse carpal ligament, as you see here in this example. Anterior interosseous nerve injury. A patient with a high median nerve injury or anterior interosseous nerve injury can have two signs: the Benedictine sign and also inability to do the OK sign. So how do you do the Benedictine sign? The patient with a complete anterior interosseous nerve injury or a high median nerve injury will be asked to make a fist. The first digit and the second digit will have difficulty in flexing. The other digits, 4 and 5, will flex. The third digit appears weak. The hand will assume the Benedictine sign or sign of benediction, which is the position during hand blessing. Hand of benediction is different from ulnar claw hand. Ulnar claw hand refers to damage to the ulnar nerve and is seen when attempt to extend all digits, leaving the 4 and 5 digits flexed. So what is the OK sign? Ask the patient to touch the tip of the thumb and the index finger together. If the distal phalanx cannot flex because of weakness of the anterior interosseous nerve, then the patient cannot do the OK sign. That is because of weakness of the flexor pollicis longus and the flexor digitorum profundus. This complication is known to occur in supracondylar fractures in children. The anterior interosseous nerve arises from the median nerve about 4 to 6 centimeters distal to the elbow, which is about 1/3 down the forearm. The anterior interosseous nerve exits from the anterolateral aspect of the median nerve. The anterior interosseous nerve runs between the radius and the ulna on the interosseous membrane between and below the muscle of the flexor digitorum profundus and the flexor pollicis longus. It supplies three muscles which lies in the deep compartment of the forearm. It is the flexor digitorum profundus, the flexor pollicis longus, and also the pronator quadratus. The flexor digitorum profundus for the index and long finger is supplied by the anterior interosseous nerve. The medial part of the profundus muscle is supplied by the ulnar nerve. The profundus have dual innervation. The anterior interosseous nerve passes dorsal to the pronator quadratus with the anterior interosseous artery and provide innervation to the volar wrist capsule. So the terminal branches of the anterior interosseous nerve innervates the joint capsule. Some more important points: patient with Martin-Gruber connection of the median nerve or the anterior interosseous nerve to the ulnar nerve at the forearm. This patient may present with intrinsic muscle weakness. Also, the anterior interosseous nerve palsy should be differentiated from acute brachial neuritis. Patient may have pain in the affected extremity. Another point, in anterior interosseous nerve entrapment, the median nerve conduction study result will be normal. However, the needle EMG of the anterior interosseous nerve will be abnormal. It is a motor nerve and not a sensory nerve. The ulnar nerve. There are several clinical examinations that are commonly used to test the function and the integrity of the ulnar nerve. The first muscle that is innervated by the ulnar nerve is the flexor carpi ulnaris, as you can see here in this diagram. Test flexion of the wrist against resistance. that will test the flexor carpi annaris. To test the function of the flexor carpi annaris muscle, have the patient flex the wrist against resistance in an ulnar direction. Test flexion of the fifth finger against resistance. That will test the function of the flexor digitorum profundus. To test the function of the flexor digitorum profundus, have the patient flex the DIP joint of the fifth finger against resistance. The medial part of the flexor digitorum profundus is supplied by the ulnar nerve. Test abduction of the little finger against resistance. Then you will test the abductor digiti minimi. The abductor digiti minimi allows for abduction of the little finger away from the other fingers. The function of the abductor digiti minimi is tested by asking the patient to abduct the little finger against resistance. Test abduction of the index finger against resistance, and that will test the first dorsal interossei. Function of the first dorsal interosseous muscle is tested by asking the patient to abduct the index finger against resistance. The first dorsal interosseous muscle can be seen and evaluated on the dorsum of the hand. Severe atrophy of the first dorsal interosseous muscle could indicate a bad prognosis for recovery of the ulnar nerve. This condition could be associated with a claw hand deformity. Always check for clawing of the fourth and fifth fingers. The ulnar claw hand deformity is a symptom of a lower ulnar nerve entrapment below the elbow, and typically causes flexion and clawing of the fourth and fifth fingers due to unopposed action of the medial part of the flexor digitorum profundus muscle. Frohman sign. It relies on the adductor pollicis. When the adductor pollicis muscle is weak, thumb adduction will not occur. The Frohman sign is used to test the function of the adductor pollicis muscle. Here is the examiner hand having a piece of paper in his hand. And when pinching a piece of paper between the thumb and the index finger, the thumb IP joint will flex if the adductor pollicis muscle is weak when there is an ulnar nerve palsy, as you can see on the left side of the screen in this patient. This is the normal pinching because of normal ulnar nerve. And this is the abnormal pinching because of an ulnar nerve injury. As a result of the ulnar nerve entrapment and the injury, the patient is unable to cross or abduct the fingers. Abduction of the fingers comes from the palmar pad interossei. Abduction of the fingers comes from the dorsal dab interossei. At the elbow, the ulnar nerve travels through a tunnel of tissue, cubital tunnel, that runs under the medial epicondyle. Tinel sign. It is a tapping technique performed to test for symptoms of the ulnar nerve entrapment at the elbow. You're testing for cubital tunnel syndrome. Elbow flexion test. The elbow flexion test is used to check for symptoms of cubital tunnel syndrome. The patient is asked to fully flex the elbow with the shoulder in some abduction. At the elbow flexus, the area of the cubital tunnel becomes narrow and compresses the nerve, as you can see here in this diagram. Holding this position may result in tingling or paresthesia in the ulnar distribution of the forearm or hand. In addition to elbow flexion, adding wrist flexion in an ulnar direction will aggravate the symptoms of cubital tunnel syndrome and induce paresthesia due to contraction of the flexor carpi annuaris muscle. This is the ulnar nerve area of sensation. The palmar cutaneous branch of the ulnar nerve provides sensation to the palm of the hand. The finger sensation is provided by the superficial branch of the ulnar nerve. How about the dorsal sensation of the hand? The dorsal cutaneous branch gives innervation to the medial dorsal aspect of the hand and to the medial 1.5 fingers. Injury of the ulnar nerve in Guyon's canal. The Guyon's canal is approximately 4 centimeters long. Both the ulnar nerve and artery enter the Guyon's canal. The Guyon's canal contains the ulnar nerve with its superficial sensory and deep motor branches. The ulnar nerve compression neuropathy can occur in the Guyon's canal. The most common causes include volar ganglion cyst. The volar ganglion cyst may protrude and grow, which could compress the ulnar nerve. This is an illustration that shows the Guyon's canal in relationship to the carpal tunnel. If you have a ganglia or a cyst in Guyon's canal, it will definitely compress the ulnar nerve in this tight space. Compression of the deep branch of the ulnar nerve is important because this deep branch of the ulnar nerve innervates all of the interossei muscle and the third and the fourth lumbricals. It also innervates the hypothenar muscles, the adductor pollicis muscles, and the deep head of the flexor pollicis brevis muscle. The adductor pollicis muscle weakness will give you a positive Froman's test. The superficial branch of the ulnar nerve is mainly sensory. It gives the innervation to the fourth and fifth fingers on the volar aspect of the hand. This is an illustration of the area of sensation for the superficial and for the palmar branches of the ulnar nerve. What is the presentation and the symptoms of ulnar nerve injury in Guyon's canal? The patient may present with pain and paresthesia in the ulnar 1.5 digits, clawing of the fourth and fifth fingers, loss of the intrinsics. It normally flexes the MCP joints and extends the IP joints. In low ulnar nerve injury, the flexor digitorum profundus is working, flexing the fourth and the fifth fingers, and the intrinsics are not working, and this is causing the clawing of the fourth and fifth fingers. You may find atrophy and wasting of the first dorsal interosseous muscle. Test abduction of the index finger against resistance. There will be weak pinch. 70% of the pinch is lost due to loss of the adductor muscle. The Froman's test will be positive due to weakness of the adductor muscle. And here you can see how the Froman's test is done. When pinching a piece of paper between the thumb and index finger, the thumb IP joint will flex if the adductor pollicis muscle is weak due to ulnar nerve injury. The MRI is usually useful to evaluate the ganglion cyst. Ultrasound may be helpful, especially if you are concerned about vascular problems in Guyon's canal. If there is a ganglion cyst and you decompress it or remove it, the patient's symptoms will get better.